vagus nerve, you can see it just takes out of the skull, takes off, and just runs right on down into your into the thorax and continues down into the abdomen. Next slide. And let's see. Oh, and this was one of the things. So here's the vagus nerve here. Oops, a little too far there. So that's the vagus nerve there. And then here's the phrenic nerve right here. Remember the phrenic nerve? So that's coming from the cervical spinal nerves 3, 4, and 5. So 3, 4, 5 keep the diaphragm alive. So that goes down to the diaphragm. So that's not a cranial nerve, that is a spinal nerve. So just showing a difference. These nerves are running near each other, but they're not. But the vagus nerve is originating from the cranium, and the phrenic nerve is originating from the cervical region of the spine. Okay, next slide. Okay, accessory nerves, number 11. It's a unique origin. They actually originate from the spinal cord. As you can see, these little branches, and little rootlets. They come out of C1 through C5 region. They go up into the skull through the foramen magnum, and then they come right back down out of the jugular foramen, and so they go up and they come right back down, and then they come down and they innervate trapezius and sternocleidomastoid muscles there. So sternocleidomastoid and the trapezius muscle there. Okay. So it's kind of an interesting nerve that like takes off and goes up in the skull and then comes right back down. So it seems kind of weird. Why wouldn't it just start there and just go right down to the muscles? But it doesn't. This is one of the few nerves that actually takes off and goes up and comes back down. Okay, next slide. Okay, and then, this was a slide I threw in here. Just there's two slides. This one and the next slide. I just want to show you that if you're ever doing, or when you're working with patients, just realize that everybody is very similar, but we're all slightly unique, and we all have slight differences. So if you're ever doing a dissection or doing surgery, those kind of things, you'll notice in this slide, here's the facial artery here. Okay, and so that's the facial artery right there. And then we have a hypoglossal nerve there, and you'll notice that it goes over the facial artery. Okay, if you look right there, it's going over the facial artery. And what I wanted to show you was that on the next slide, that it goes under the artery in a different person. So next slide. So here's your, if I can find it, hypoglossal. It's misspelled nerve, and notice it goes underneath. If I can actually draw an arrow, I think I could. It goes underneath the facial artery right there. So there's a facial artery coming across the top here. So the stuff is in a very similar place, but it's not always exactly in the place. It's not always, everything's not always on top of something else exactly as you think, exactly as you learned it. Things are sometimes slightly out of place in different people. So anyway, just a little note to put in the back of your heads. All right, next slide. Okay, here's hypoglossal nerve again, just showing this. So here it is down here, right there. So just showing another view. You have up here, you notice there's the pons. So here's the pons. So there's medulla, here's cerebellum there. So we're looking at the hypoglossal nerve coming down out of the skull there. All right, next slide. Okay, so here's back to the summary of nerve type and function: olfactory through hypoglossal nerve, and the nerve type sensory motor. Some of these I wanted to point out. We talked about parasympathetic and sympathetic and parasympathetic systems. So these guys have some of these have parasympathetic actions to them. So those are involuntary, control involuntary muscles, and so those will be like some things like say gag reflex, those kind of things that you don't control, just sort of happen. Okay, that would be something that the glossopharyngeal and vagus nerve are both involved in. All right, for the most part, these are sensory or motor, but there are some parasympathetic aspects to them. And like oculomotor, the parasympathetic aspect of the oculomotor would be in the ciliary muscles. So and for the for dilation of the pupil. So you don't control that. That just happens when you have a bright light, your pupil contracts, and you go into a dark room, your pupil expands. You don't have control of it. So that would be parasympathetic function of the oculomotor nerve. Okay, next slide. So, and this is just back to that slide I showed you in the very beginning, talking about all the muscles and their actions. So I'm not going to go over this again. You can review that in the PowerPoint if you want to. Next slide. And I did a summary table, put together a summary table for you. So this is just a overall cranial nerves and their function, their names and functions. So next slide. Okay, what I wanted to also show you was some other examples of what happens with some defects in some of these cranial nerves. So here's cranial nerve number 3, the oculomotor nerve. And you remember that one branch of it, it innervates the levator palpebrae superioris muscle, which is the upper eyelid. And so you have ptosis and a drooping of the eyelid. And so here you have unilateral, so it's on one side. You see over here. See on the left side, the patient's left eye is drooping, and then on the right one, the right upper, the right one droops. So that's damage to, or maybe a congenital defect in the oculomotor nerve, cranial nerve number 3. And then you have on the bottom one, you can't see because I'm in the way here, but it's a bilateral, so both eyelids droop. So they look sleepy. So the upper eyelid droops. And that's probably congenital, although it possibly could be caused by head trauma. Okay, next slide. Cranial nerve number 4, the trochlear nerve. So it's the superior oblique muscle, and that rotates the eye. And in this case, I have a view of the right eye is over here. That's the slide I showed you earlier. So, but you notice this person's trying to look straight ahead, but his left eye wanders off up to the right. And so a lot of times when you see these patients like this, you'll see them and they'll tilt their head so that they compensate for some muscles that aren't working in the eye. So in this case, the superior oblique should be grabbing that left eye and rotating it. Rotate. It hits on the inside, so rotating it down so it holds in place. But it's not working, so the lateral rectus muscle is pulling on it, so it pulls that eye and it rotates back up like that. So, okay, next slide. Here's some other examples of lesions of cranial nerve number 4. So you test it by having them look straight ahead and then look down. In this case, the patient looked down into their left, and you notice that the right eye. So here. This looks all okay. They can focus front, but when you have them look down into the left, the right eye over here isn't able to go to complete what's called you can't complete the torsion, the rotation all the way down and look in, which is what the superior oblique it pulls on the eyeball up there and it rotates it so it rotates down, so you look down. So they're not able to completely do it, and it's not as obvious. The eye doesn't stay like immediately ahead while the other one looks down. It can do that, but a lot of times they do move. Both of them move somewhat, but one just doesn't move as far as the other one. So you have to remember that when you're doing these evaluations on people, that it may be somewhat subtle. It may be very subtle. It may be somewhat subtle. It may be very obvious. So there's a whole range of things that you could see in this. Okay, next slide. And here's some lesions of cranial nerve number 6. So this would be a palsy of that. And so 6 is the abducens nerve. And so here you have the guy's looking straight ahead. Here you have him look to the right. Or let's have him look on the bottom. Have him look to the left. Then you have him look to the right. And you notice that right eye over here is still staring straight ahead. So it's not able to abduct. It's not able to look to the side. So that tells you that there's a problem with either the muscle or the nerve, and that's the abducens nerve, one of the two. and it won't abduct all the way. It abducts maybe slightly just because you have action of all these other muscles on the outside of the eye. They have 6 muscles out there, and they all work in concert. So you can move the eye just a little bit, but it doesn't. So they won't focus. And so what they'll do is instead of like try and move their eye, look over there, they'll actually turn their head. So they're both looking. So they're always looking that way. If they try to look to their side, they can't. So they'll have to move their head to actually look to the side. Okay, next slide. Here's cranial nerve number 7. This is called Bell's palsy, and if you ever go into primary care, you will probably see this. You get this to maybe viral infections, sometimes traumatic injury, sometimes diabetes complications. You'll see this in kids, it's probably more viral, or maybe a traumatic injury. Affecting cranial nerve number 7, the facial nerve, so you aren't able to move the facial muscles. And a lot of times it's on one side. Problem is that it looks like a stroke. I mean, if somebody walked into your office and looked like this and wasn't able to move the side of the face, the first thing you think is stroke. That would be so. If you do your test and exclude stroke, you're left with Bell's palsy is a likely candidate for what's wrong. Okay, next slide. Oh, here's I just wanted to show this one. This is a friend of mine who had a lesion on the cranial nerve number 8. It's called a vestibular schwannoma, or acoustic neuroma, or acoustic neurilemoma. Now, if you remember the neurilemma, that's the Schwann cell, and that's the Schwann cell. Remember, you have your axon, the Schwann cell's wrapped around the axon, right? So that outside part with the cytoplasm, there's cytoplasm left, and the nucleus is still out there on that outside part. That's the neurilemma. There's a little space there that has cytoplasm in it. So this tells you this is a Schwann cell tumor. So that's why it's called a schwannoma, or acoustic neuroma. So it's a tumor on the acoustic nerve, or the vestibulocochlear nerve. So, or it's the vestibular schwannoma. So vestibular cochlear nerve. It's a tumor of the Schwann cell that's around the vestibular cochlear nerve. So that's where all those different words up here at the top come from. So acoustic neuroma and acoustic neurilemoma. So anyway, this is the MRI. This is looking face on at this friend of mine, and she didn't have any symptoms, but she went and just had, she just didn't feel right, so she went and talked to her doc and talked them into actually giving her an MRI. She's pretty convincing. So anyway, and it went and it lit up. And remember, talked about MRIs before. MRIs, if there's if there's water, that tends to light up nice and bright. So you see this nice bright white spot right there. So that's on the right side, and that's cranial nerve number 8. So it's a schwannoma, acoustic neuroma on cranial nerve 8 on the right side there. So here's another view, and this is another MRI view. And remember, you're looking. Remember, your view is up from the feet. So this would be on the right side here. So you're looking as you're looking going up through the base of the brain towards this. And so here is the tumor right there. So she decided to have surgery, and so she went and did surgery. And so she went in on a Monday morning and had the surgery. And they went. There's 2 ways to do it. They go directly in through the eardrum. If they don't believe that they can save the nerve, they'll go directly in, or they'll go in back, sometimes back behind, and try to save the nerve. That's what they try to do. But it was wrapped all the way around the nerve, so they just had to clip it out. These tumors are not malignant. They don't, which means they don't spread, but it would grow. It's very slow growing, but it would grow and grow and grow and grow and grow, and eventually would cause problems. So she decided to go ahead and have it taken out. So that was her issue. So she went on a Monday morning and had this surgery, and then they removed it. And so then when she woke up from surgery Monday evening, then she couldn't hear out of her right ear. So it was very disconcerting, and also caused a lot of balance issues. And occasionally she and I would meet for lunch, and she would get out of her car, and she would like kind of sway back and forth. I'd give her a push on the back and say, "Come on!" And once she got walking, she was fine. And you learn ways of compensating. You like put your hand out like along the wall when you're walking down a hallway. You can touch the wall, and that gives you some proprioception coming from a different part of your body. So it tells your brain where you are. Otherwise, sometimes you lose your balance a little bit. So anyway, so she's doing fine, but except for the loss of hearing, loss of balance on that side. So, but other than that, she's doing really well. So, all right, next slide. Okay, we would be doing some lab exercises, and these are actually a whole lot of fun, but unfortunately we can't do them. So since we're not together, I will give you some videos to watch of these lab exercises. You can actually do these yourselves if you'd like, if you have, and this is actually a lot of fun to do with if you have kids or spouse or whatever. So, but I'll run through these real quick and show you what they are. So what you can do, we actually have a box in lab that actually has all the stuff in it, but you can sniff things. You can sniff coffee grounds, spices, aromatic oils. And so if you can smell those different things, then that's olfactory nerve number 1. So easy test. Olfactory nerve number 2, you can read an eye chart. So ability to read it is normal. So you read off the letters off that. And then olfactory and optic nerve, then cranial nerve number 3, oculomotor, and trochlear and abducens. You can observe the eyelids and like open your eyelids up and just relax them and make sure that they're not drooping. And so that would be oculomotor nerve. So the levator palpebrae superioris muscle there. Then you can the other thing that you do with oculomotor nerve is you draw an H, and so you take your patient and you start on one side and you draw and say follow the pin, and you draw down and then up and then across and then up and then down, and so you make an H in the air and watch their eyes, and can they follow that pattern all the way across. So it goes up and then down. So can they abduct the eye, look over that way, and then without moving their head, and then across and follow it all across, and then go up and down. So that'll give you a good readout on cranial nerves 3, 4, and 6. Then you can also take a pen light and shine it on their pupils in a darkened room. And you don't shine it directly in their eye. What you try to do is do kind of unless you're trying to look in their eye, but usually you do it at a kind of an angle, and you bring it up to their eye, so it kind of like hits their eye, and you can watch the pupils constrict. So that would be oculomotor, the cranial nerve 3. 5, you can actually touch the cornea, so actually touch the surface of the eye with a little wisp of cotton, and the person will blink. That's normal. And also, you can take a tongue depressor, or if you have something else that's wooden thin piece of wood in the house that's not going to break, and have somebody bite down on it and try to pull it out, and then be good resistance pulling. So that would be your chewing muscles, your masseter. So that would be cranial nerve number 5. Number 7, you can smile, raise your eyebrows, whistle, close your eyes. And so if you go to a primary care physician, they'll probably have you do this, and you don't even realize what they're doing is actually looking at the facial nerve, cranial nerve number 7, as well as some of the others. Also, you can use a tuning fork to listen for hearing in each ear. And also stand straight and with your eyes closed, and do they sway back and forth. And you'll find that if you do this test on older people, they don't have as good ability, don't have as good equilibrium, so a lot of times they will sway. Cranial nerve number 9 and 10, you can say ah, you can gently touch the uvula way back, the little dangly thing that hangs back in your throat with a long Q-tip. And if they have a gag response, then that's normal. And if they don't, then they sometimes, if you've had Bell's palsy or those kind of palsies, you may have, if you had a viral infection, some people have lost that gag response. You can also use quinine and touch the back of the tongue back there, see if you can taste that. So that's checking 9 and 10. And then 11, shrug your shoulders. So you hold down on their shoulders, and then have them try to shrug up. And there should be, can they shrug up? Can they push up against your resistance? You don't have to like push them down hard, but you can hold their shoulders down. So and see if they can push them up. And both sides should have equal strength. Then also stick out and retract your tongue, and make sure the tongue doesn't deviate from one side to the other. So it should go straight out and straight back. If it deviates from one side to the other, remember these nerves, just like spinal nerves, come out both sides, and so they're innervating both sides. So if it deviates to one side, that means one side, one nerve, or muscles are weak on that side or aren't working on that side. So so always remember, they're always looking in pairs. So you always have to do left and right. Okay. All right. Next slide. So here's just here's what I would have handed out in lab, just so you can test all these muscles. So you don't have to know this. This is just exercises for you, just so you can test these and have fun with these. Okay. All right. Next slide. All right. So this is the end of the cranial nerves. So this is just a little cartoon that I pulled off the internet, and so here you can showing the different things that the different cranial nerves will do. So I'll post some videos for you to watch for cranial nerve exams, or one or two. You can choose between. I'll probably just pick one for you. And then let's see. Okay, so then all we got left is really the last class session. That will be over the let's see, integumentary system and endocrine system. Unfortunately, since we lost a week for one class, we lost 2 class sessions for the other class. So basically, it means we've got to kind of cram all the stuff in at the end. So I've done 3 somewhat complicated lectures, but hopefully you guys will get this. It'll be easy. So for this, you really want to know the names of nerves, what they do, sensory or motor or both, and the foramen in the skull. So okay, so I will see you next time. Have a great week. Bye.